fundamentally, what is a contract? This is a working definition that I've kind of come up with. Nothing too technical in that. As you will read, it says a binding promise to do or not do something which can be enforced. What essentially that means, it's a voluntary obligation that you agree to take on, and it can be positive or negative. So you promise to do something or promise not to do something, and there are examples of both kinds of obligations in your contracts. Elements of a contract. There has to be offer and acceptance. What that means is the terms of the offer have to be matched in the acceptance. So in, say, an example with Telstra, if you say, Telstra, I love that phone, I would like to buy it, and they say, that's great, it's $500, and you say, oh, well, I'm willing to pay $400. No contract has been made because the acceptance didn't match the offer. Your $400 that you've offered is actually a counter offer to their initial offer of $500 to buy the phone. The second point below that is that the contract must be supported by consideration. Consideration, for kind of in a basic sense, it means the money that is exchanged, which is required to for a contract to be enforced. Now, there's no requirement that the money has to be any certain amount. So again, with the phone, it would be a valid contract if it was for 1 cent, but there has to be some kind of exchange of obligations. There must be an intention to create legal relations. And what that means is that the parties are really wanting to formalise their agreement in the terms of the contract. So if I was to say, let's all go out for a drink afterwards, I'll pay for everyone. Yay. Is that a contract? Probably not, because there isn't an intention to create legal relations. And the terms have to be reasonably certain so they can be enforced. So again, in the last example, you could see how that wasn't particularly certain. So the terms of the contract are those that are express, and express terms can be written or they can be oral. So again, a contract can be formed by verbal agreement, in which case the terms would be oral. And there are also implied terms. Now, implied terms are ones that are so obvious that you didn't even think you need to write them down. Of course, what happens is when it goes to court, one party says it was so obvious, the other party will say no, it wasn't. So that's kind of an inherent conundrum. But essentially, it's recognising that the contract will have the express terms that you've agreed on, but then there'll be others that you thought, well, we don't need to kind of write everything down because it really was so obvious. In terms of how we interpret the terms of the contract, the basic rule is they're given their plain meaning, so it means what it says. And I've written under that must means mandatory. Mandatory as in something you have to do, an obligation that you've promised to perform or not to do something. And we'll come back to why that's important in a couple of minutes. So you can go to law school for 5 years, and what you learn is that it means what it says most of the time. The meaning of the terms are determined objectively. What that means by determined objectively is that a reasonable person in your position, what they understood the contract to mean, not what you thought it was meant to mean. So that's something to keep in mind. When you're trying to work out what that reasonable person thought the contract was meant to mean, you can also consider the surrounding circumstances known to the parties. So again, in your example, you've got the Medicare Local on one side of the contract wanting to engage you as contractors to perform certain services. So you can consider that when you are trying to interpret the terms of the contract. A bit of a joke at lawyers' expense. Often you'll see contracts that are written in very complex language, and the truth is there's no real reason for that. There's now a trend to simplify contracts to use plain English. They should be accessible. There's no reason to use particularly archaic language, but some lawyers still hang on to that because that's how they were taught. And now talking about what it means to breach a contract. Quite simply, it's if you don't do what you promised to do. How is compensation measured? It's an amount as if pretending that the contract hadn't been breached, and to try and put the party back into that position. Sometimes that's quite difficult to measure, and a court can also order you to do or not do something so that the contract isn't breached. So that's the last dot point, which is in order to perform the contract or not to breach the contract. That's referred to as an injunction, if you've heard of that term. News, for example, recently, I think Essendon seeking an injunction. Legal jargon that's used in contract law. Repudiation. Repudiation is really a type of a breach of contract, but it's when the breach is that you're saying you are not interested in performing any of your obligations under the contract. That can be complicated because if you've got two parties to a contract, imagine they're not getting along, they're not really seeing they're not seeing eye to eye. Eventually one party will say, well, that's it, I'm out of here, I don't want to be in this arrangement anymore. Now, if they do that too soon, before the other party really has breached their obligations, then the party saying that they want to get out of the contract can effectively be repudiating the contract. So that's what repudiation means, not willing to perform your obligations at all. A contract and a deed. Does anybody know what the difference is between a contract and a deed? You've probably heard both terms used. So I think that's kind of how people sum it up, and that's basically correct. A deed is a special kind of contract which doesn't require consideration. So remember, so consideration is a thing that is exchanged. Sometimes if there's only one party promising to do something, then you would use a deed. So a deed would be used often in a deed of confidentiality because you're saying, I'm taking this information that's confidential and I promise not to disclose it to anyone, but I'm not getting paid to do that. There's nothing actually that's requiring you, or you're not getting any benefit from it, which is why it would be done by deed. Frustration of a contract. That's when something comes up that neither party could have foreseen, that basically means that the parties are discharged from their obligations. I put in there the example of a natural disaster. If we were to be, flooded out of here, arguably the contract would be let go of our contractual obligations. The case that was on frustration back in the early 1900s was there was a man wanted to rent an apartment for a couple of days in London to watch the King's coronation procession, and they agreed on the price, but they didn't say any particular reason why he wanted to rent the apartment. Now it turned out that the King was sick when the parade was due to go ahead, and he said, well, the contract's been frustrated, I want my money back. And the court said, yes, that was legitimate because the purpose of the contract, which was to watch the King's parade, had been frustrated. It didn't go ahead. So you can keep that in mind if you're trying to work out if your contracts are being frustrated. Indemnity. An indemnity is a kind of term in a contract where one party promises to protect the other party from liability. And the most common example of that is an insurance agreement. That's a kind of an indemnity. The insurer is telling you they will be liable for the damage caused. And important to note that the agreements that you've entered into with a Medicare Local include an indemnity clause. Okay, turning to your contracts with a Medicare Local, thinking about what you promise to do. You promise to provide the services that you've specified, so whatever number they are per week, meet the performance standards, maintain insurance cover, provide information to the Medicare Local by way of invoices so they can actually pay you, provide access to information about the patients that you see, meet reporting obligations and comply with privacy laws. And remember earlier we said that must means mandatory, so these are things that you are expected to do because you have entered into a contract that says you have to. What does Medicare Local promise to do? Provide certain training and support to you and also to pay you obviously for providing the services. Turning just to some of the specifics, looking at them in a bit more detail. Again, I don't think this will be new to anyone, but it's helpful to remind everyone what the contracts actually mean. The service and performance standards that you have agreed to abide by include the professional standards of your relevant professional board, if that's relevant to the work you do. So if you're a nurse, obviously the Nursing and Midwifery Board of Australia or the Psychology Board. And also the service standards and operation guidelines and the clinical governance framework, which we'll hear more about later. Also in terms of the reporting obligations, there are very specific reporting obligations where you have promised to tell the Medicare local certain things. An important one is if AHPRA commences an investigation into your conduct or practice, then you're meant to tell the Medicare local of that within 24 hours. There's also duties to report to the referrer to give them feedback about the nature of the referrals, and legislative reporting if you make a report to Department of Human Services, for example. What else have you promised to do? Provide access to information. You're obviously required to maintain certain records and to obtain client consent to pass those records onto the Medicare local if required. There's also a duty to assist the Medicare local and to facilitate access if you are asked to provide access to your records. Remember at the start we spoke about what a contract is. It's a promise to do or not to do something. We've spoken till now about what you've promised to do, but you've also promised not to do certain things. I've put some examples up here. One of them is obviously important to everyone working in a clinical environment. You've promised not to disclose information which would breach the confidentiality clause. Essentially, if the client doesn't consent, then you're not able to disclose the patient information to anyone, and obviously not to communicate with the media about matters that are relevant to your contracts. Understand why it's important to really get what the contract is about before you agree to it, before you sign the contract. That means you should read the contract, ask questions if you don't understand anything, and clarify any clauses. Does this mean that I have to do this, for example? Consider what it means for you if you are unable to meet the particular requirement of the contract. And obviously that's good advice for any kind of contract.
So examples might be frequently thinking of a client when away from work, frequently planning another client's care around a particular client's needs. Yeah, it's very important to be able to build rapport. So there are certain things that you probably feel safe to talk about. Maybe it's hobbies or certain things that you've got in common that you can build rapport over. But there again need to be boundaries about how much information. You wouldn't give information about where you live or your family, or if somebody's asking you those sort of questions. So some examples of under-involvement. So disinterest in the client, disengagement from the client, continually asking colleagues to take care of the client if it's not clinically based, ignoring the client's requests, or talking about the patient in a derogatory manner or dismissive sort of manner are certainly areas to think about under-involvement, and is it appropriate to refer on this patient if you're having challenges about working with somebody. In a lot of those circumstances, there was an example of a GP who, in the clinical setting, was talking to a woman who'd recently divorced, and she was talking to the GP about going and getting some extra work as a cleaner. So he invited her to clean his house. I thought that was quite okay. Over a period of time, he ended up being at the house while she was cleaning. A little bit more time, and then they were sharing a cup of tea every time she was cleaning the house. Eventually that led to going out for dinner, and then eventually that led to having an intimate relationship. But what ended up happening was that GP ended up getting a letter in the mail that he'd been suspended. He was reported by the psychologist who was working with the woman, who was obviously disclosing all this relationship and how it was progressing. So for that person, they must have thought that situation was okay. So it's really important to make sure that, you know, when these transgressions happen, that you bring that to supervision and say, is this okay? Do I need to review where I'm at with this client? So these things do happen. Using the clients for business dealings. There's certainly examples of that. Developing friendships with clients. Does anybody know what the requirement is about, you know, having any contact with a client after having a professional relationship? Yeah, it's 2 years. 2 years from discharge and no contact in between is the minimum requirement. Okay, another examples of giving a patient who is crying a hug. Now I put question marks next to that because I really think that that could be contextual. If you're a professional working in an inpatient unit, you know, you're working with somebody long hours, if somebody's crying you might put an arm around them, but I guess it's got to be quite open and obvious, not behind closed doors. I think it's more about the intent and making sure it's open and transparent. But I've been in lots of settings where you raise that and there's all these heads go, no, possibly not, it can't happen. And it does sort of raise warning bells for people. But it really has to be contextual and about the intent. So that's a good example of that. Calling the patient darling, pet, all those sort of things, you've probably heard that before. Some people use those sort of terms for everybody. So I guess it's just being careful about when that's applied, particularly if somebody doesn't know you well and then you start calling them darling. So it's important to think about. Promising a patient that you will visit them in hospital and then go and visit them. And that's certainly happened before as well. Has anybody got any? Transference and counter-transference I think is important concepts to think about, and I'm not sure how many of you use it, but this might be going back to basics for people, but it's always helpful to come back and review these concepts and how you use these concepts to reflect on the work that you do. But particularly for counter-transference, you know, when a patient's not progressing like you might expect them to, and is that appropriate for that person in the presentation that they have? So mechanisms to assist in maintaining professional boundaries is of course. So when looking at scope of practice, how to ensure that people are working within their scope of practice within their accepted range of clinical practices within their particular discipline is important to review. Position descriptions are very helpful to guide us if you're in an employed position. Also guideline documents also help us with our scope of practice and knowing the boundaries of what we need to work within. So operational guidelines for ATAPs, MNIP and Partners in Recovery are examples of those. So I'm going to go through those in a bit more detail. So ATAPs, it's very clear what the scope of practice is, and this is listed within the guidelines. MNIP program, work closely with medical professionals, work with people who have severe and persistent mental health disorders. Services can be provided in a range of settings, in a clinic, community or home visits. It's a very flexible model of care. The nursing services that are explained in the guidelines outline establishing a therapeutic relationship, liaison with family and carers, regularly reviewing the patient's mental state, administer, monitor and encourage compliance with medication, providing information on physical health care and coordinating clinical services and service linkage. So familiarising yourself with understanding your funding documents, codes of conduct and practice standards. So each discipline has their own practice standards as well. So again, coming back to how do you know you're working within your scope of practice is using your clinical supervision and clinical review mechanisms to guide your practice.
Thinking about some of the potential occupational health and safety incidents that might present themselves during your working day. But I'll just give you that is a definition that we're using, and so an occupational health and safety incident is an event or circumstances that occurs in the work environment of the service provider, being yourself, where harm was caused or potentially caused to at least one person, being either you or a staff member or visitor in the work environment where the incident relates to your client. So there might be a scenario that we want to know about where your client is in fact the one who's caused the occupational health and safety incident. And that would obviously need to be reported and enable us to do an investigation and, for instance, make sure that if that client is going to be referred perhaps to another provider, that we put the appropriate checks and balances in place to make sure that that happens in a safer environment.
And so the idea is to try and integrate health and safety into the process that you guys are doing for them and that they're doing for you. Under the legislation, this is an employer and these become employees. So the employee doesn't have to be a person, like a natural person, it's an entity. Now, they're also an employer and here's an employee. And so the legislation basically allows for multiple tiers or multiple levels of employer and employees. And how we work out safety is by negotiation and by contract. That's what Alan spoke about earlier on. What's in the contract? What does it say you're going to be responsible for? What does it say that your other employer is going to be responsible for? Here's the key though. A duty like this one can't be delegated. So there is no way that Medicare Local or the clinic can say to you, no, we absolve ourselves of our duty for OHS, it's all your responsibility. They can't say that, okay? However, what they can do is they can pass on responsibilities. And so in order for Medicare Local, if we go back to the example of being assaulted in your clinic, for example, Medicare Local doesn't, do you want them to come into your house and say, oh, well, pick up the carpet and you know, telephone on that side over here and bolt all the pot plants down? Do you want them to do that? No. And so that's not what you want them to do. Yet they still have a duty to make sure that you're safe. And so the way they do it is by saying to you, well, how are you going to make your own place safe? And therefore, we therefore refer responsibilities, but we still hold the duty of care. That's what that is. The employer must, so far as reasonably practical, and that's kind of like, there's 5 parts of it, but it's within reason, provide and maintain for employees of the employer. Contractors, subcontractors, direct employees, all of that arrangement, a working environment that's safe without risk. And working environment has these things in place. Plant is the equipment you use. That has to be safe. Do you use any clinical equipment in your physio background? So we have plenty of equipment in our job. Anybody? No. So there's not really a lot in here that you need to worry about. What about systems of work? That's the way you work. So your manuals, your practice manuals. All right? And so that's something you need to worry about. What about substances? Now, we normally think about substances as illegal, but this could be consumables in the workplace. Yeah, that's about the chemical one, the material safety data sheet. All right. Does that apply to drugs, for example? Yes is the answer. Okay. What about workplaces have to be safe? So how does Medicare Local make sure that your workplace is safe? Well, they ask you to determine what the risks are and then ask you to tell them how you're going to make sure it's safe. They don't delegate the duty, they delegate the responsibility to do that. Welfare. Let's say they know that a potential client has got aggressive tendencies or triggers which are going to set them off. Should they tell you that? Yes. Why? Isn't that privacy? Which comes higher, by the way? OHS law or privacy law? OHS law overrides it all. Okay? Now, you need to be careful because there's still obligations under that stuff. But the reality is, if they know something which is going to affect your safety, they're obliged to tell you. What about instruction, training and supervision? That's what this is today. It's part of them fulfilling their duty to make sure that you have a safe workplace. So it's not hard when you look at it. Remember though, in this arrangement, they're also the employer. They have the same duty. And so what you need to do at the end of the day is make sure you're safe and decide who looks after the various elements of that and make sure it's in place. Medicare Local has the right to ask you about how these things work, and that's called a risk assessment or a risk assessment document. Can you think of an example where you might actually place your client at risk through your actions or omissions? What about if you've got a dog at home? Could that be potentially place them at risk? What about a cat if they're allergic to cats? What about one client assaulting another client as they pass through? And so this is, as employees, we need to make sure that we look at what could happen through our actions. Now, your actions might include whether you have a first aid kit or not. Your actions might include whether, in fact, you have separate doors, or whether there's members of the family in your home, or at other people at the clinic. There's lots more, as you can imagine, but 25C, cooperate with his or her employer with respect to actions taken by the employer to comply. And really what this means is if Medicare Local says we need a risk assessment to understand about your risks and about the way you solve them, that's actions taken by Medicare Local to maintain their duty, and so you're obliged to do that. Exactly the same as if they say to you, if you're going to be working at a client's residence or at a place and it's going to be where you're going to be travelling or where you might actually be working in isolation, you need to have a process in place to look after yourself. Is that a real risk, by the way? Let's say you're going to maybe not around this area, but certainly if you're working up around Collingwood area, going to a set of flats, is there a risk of working by yourself up there? So how are you going to manage that? Absolutely, that's as simple as it gets. And call them when you get out there. And if I don't call by that time, then this is where I'm going to be. That's as simple as it needs to be. What's the consequence if you don't have that in place? Well, that's the problem. Yeah. Now, Medicare Local is worried about that. And so the way they manage it, do you want them to say, you have to have a beeper, a PLB, and you don't want that. You want to, okay, this is how I manage that. Do you think they'd have the right? If you said, well, I'm really careful and I'm going to just take care, and if I get into trouble, I'll ring somebody. Is that acceptable? No. So if they turn around to you and say, that's probably not a level of safety which is enough, would you be offended by that? Because that's what they need to do. They need to look at their duty and say, is that level of control adequate? All right? And they base it around the standard. Now, we don't want them to tell us what to do, but we want them to give advice if it's not good enough from their bank of experience. That's basically risk management. In terms of controls, and don't get worried about this, the regulation specifies that when we approach controls of hazards in a workplace, we should try and control them in this arena here. So basically elimination doesn't mean eliminate the client, by the way, it's eliminate the risk associated with the client. So if the risk is, oh well, when I'm working with them by myself I've got a risk of assault, then make sure you have a second person there. That eliminates that risk associated with it. Substitution might be in a different location. That's exactly what you said. When I do my original assessment, I don't do it in my home, I do it in another place which is a public place or a more contained place. That's exactly the answer. Engineering controls is bolt everything down so they don't assault you. It's also about things like what steps do we have if we're having people in wheelchairs or have a disability coming in, do we actually need to put ramps in place? That's an engineering control. Not about them bashing you up, but more about well, what's their access requirements for disabled people? Administrative controls are policies and procedures. Now, we can always give you a motorbike helmet and elbow guards and knee guards and a cricket box and all those things. That'll protect you as well, but probably not as well as the other ones. So when we look at controls, we should try and control up into here. What could I do to eliminate the risk or to significantly reduce the risk? And that's the obligation under law. Risk management requirements. So, in summary of what I've been saying, all contractors should evaluate the risks associated with the task they're undertaking. This is not a hard process. Oh, by the way, write this down. WorkSafe Victoria has a free consulting service for small to medium businesses. So businesses under the 20 employee mark can actually get 3 hours of free consultation from WorkSafe. It's probably worth about $1,000 in terms of free service. It's called the OHS Essentials Program. And if you just go to WorkSafe or ring WorkSafe and say, how do I get access to the Essentials Program, then they'll help you. And so they'll help you work through this process. And it's a great way to get to, some one-on-one. They engage people like us, and we come and sit down in your place with you and say, how do I work this out? And this is what you need to do. All right? So that's a great, just thought I'd mention. I didn't talk about that before, did I? That's good. Risk management strategies should be documented. What does that mean? Basically means write it down. Think about it, plan it out, and put it into a documented form. A copy of your risk management documents should be provided to these guys because they have the duty, so they need to know. And if they're hassling you saying, we need a copy of the risk assessment stuff, then do something about that. Issues associated with your ability to manage risks. So, if you identify a particular problem and you don't know how to fix it, what do? Here you go here. Or ring WorkSafe, all right? Oh, actually, I should tell you, WorkSafe changed its name last week. It's no longer called WorkSafe. Just to confuse everybody, it's now called the Victorian Work Cover Authority. Notifiable incidents. Section 37 and 38 of the OHS Act. This is different from the other notifiable incidents you have under a clinical setting. WorkSafe Victoria has requirements under the Act that you will notify them immediately any of these events occur. This was not written for mental health nurses. This is not written for psychologists. This wasn't written for anybody except construction industry, except the law applies to everybody. The requirement you need to know. The section of the Act, section 3738 of the OHS Act, it's called the Notifiable Incident Act. You need to know that if one of these events occur within your workplace under your management and control, which means if you're there and you control the workplace, this is your responsibility. If you're in somebody else's workplace, they've got the obligation to do it, all right? But they need to know they do it. So here's the requirement. They have prescribed injuries, they have prescribed dangerous occurrences. Look at the injury bit. So the top of that little bit there, the first one says death. I don't know, do you consider death an injury? I have a trouble already with the whole process. If a death occurs in your clinical setting, then you've got an obligation to ring WorkSafe as an employer, as an employee within that workspace, all right? 132360. You ring it up, the person on the phone is going to say what occurred, you'll give them a brief summary, and they'll tell you there and then whether it needs to be reported, okay? Write yourself a little note. Always, always, always take the reference number. Now, they don't always offer it to you. Take the reference, say, can I please have my reference number? Because it's only a $33,000 fine to fail to do this, so it's probably worth getting the reference number. Here's the next bit. If they say, yes, it is notifiable, there are two things you must do. Firstly, secure the area as if it was a crime scene. So if it's your home clinic, then you must not allow anything to go in to disturb that unless it's in direct requirement to preserve the life. All right? So the ambos are allowed in, for example, but by the way, if they're already dead, then they ain't got much to do anyway. But if it's a serious injury, which is the next one's on the list, sometimes you're just going to have to lock the doors and wait for them to get there. The second thing you must do is that there is a prescribed form you must complete within 48 hours of your verbal notification. Now, hint here. Question about 4 on the form says, in your opinion, what happened? Resist the temptation to put anything in there apart from currently under investigation, because you could actually convict yourself in there by saying, oh, well, I failed to lift the mat up and they tripped over and bashed their head and now they've died. I'm sorry, you've got a problem, all right? So resist the temptation, put in there under investigation, which it probably should be anyway, all right? And then deal with that later on. Do you need to notify Medicare Local? Definitely, it sits under those requirements to notify them as well. Anybody been to emergency recently? When you walked in, did they ask you the question, was this a work-related injury or not? Yes. They normally do, okay? Now, they have a hotline back to WorkSafe, so it's work-related, they notify WorkSafe, but not your requirement. So that's how WorkSafe knows you haven't notified if it's an emergency.
If you're reasonably trained to do CPR,
yep.
CPR if you're not a medical person.
Mm-hmm.
What's your responsibility?
The Wrongs Act, Division 9, Section 37. And that talks about the obligation under the Good Samaritan Act to look after them. Okay? It's a real hard question. As a physio, we are trained in first aid. Supposedly we can give CPR and supposedly we can do a whole lot of stuff. Gee, the last time I did a first aid course was when I was an undergraduate, 25 years ago. I'd know what to do, but in an emergency, I'd probably jump in and do it. But I'd ring 000 in reality. I had a case last week, and what it was is that it was a workplace, and an employee came up and saw his manager and said, "Listen, I've got severe chest pain and numbness down my arm." And the employee said, "Let's grab the first aider." So the first aider came and said, "No, I don't think it's a heart attack. Just sit down and have a cup of tea, see how you're going." Like, no. Now, they had one of the defib machines there. And so they were really keen to use it once. And so they were going to, like cardiac surgery, I'm sure that they were going to cut. The reality is no, ring 000, that's what your obligation is. So in terms of the first aid bit, well, gee, you don't have to be trained to provide first aid. But if you are trained, is that a clinical expectation? And if that's a clinical expectation, then you've got an obligation to do it. So let's finish off. So we got that, the hospitalisation. Emergency is not hospitalisation. They've actually got to get past the emergency to be admitted to hospital. The next ones are dangerous occurrences. Can I borrow yours? Okay, the dangerous occurrence ones. Collapse, overturning and failure or malfunction or damage to a specified item of plant. Now, this is a D4 dozer. This is a high-end air compressor. I don't think you have any of that stuff in your kind of work zone, do you? It's not your car. So the specified item of plant is licensed, regulated plant. Tower cranes are involved, escalators and elevators are involved. You don't need to worry about that one. Collapse or failure of an excavation shoring support, we've been through that. Collapse of a part of a building or structure. Now, you'll notice under the title, it says in the immediate vicinity of a dangerous occurrence. So you go to work tomorrow where you practice and the ceiling's fallen down overnight. It's not notifiable because nobody was there. You're standing there and the ceiling falls down, then you're in the immediate vicinity of a dangerous occurrence, you ring. All right, that's the way it works. And again, you ring 132360, they might say no, in which case you don't have to worry. They say yes, preserve the site, WorkSafe will come to the investigation. This is just a requirement of law. By the way, you need to tell Medicare Local about this stuff. If in doubt, 132360, hi, I don't know if I should, but I'm just telling you about this notifiable incident. They'll say yes or no, say what's my reference number, and that's it. If though they say yes, we want to know about that, you need to move into the next bit, in which case I would then certainly get on and have a look at your obligations to fill the form in. There's a lovely publication came out in 2007. It's called The Guide to the Incident Notification Regulations, Section 37, and it came out, you want the 3rd edition one, and that tells you everything about, the falling of counterweights from big tower cranes and all the stuff, but it tells you how to fill the form out.
So what we hope that you also take away from tonight is around clinical governance and an understanding around that our board at Medicare Local has the ultimate responsibility to ensure that clinical performance is in line with national, local and state standards. The board also has the ultimate responsibility for the service standards of care and for providing the structures and environments that facilitate the delivery of high quality care. And to ensure a successful implementation of our clinical governance, it relies on a really strong working relationship with our service providers. And what we want to really emphasize is that we're all working towards the one aim. We want our clients to have better outcomes because of the interventions that they have received, and that those interventions are safe, evidence-based and effective. So, namely, I'm going to be talking about 2 changes to our process tonight. We're going to talk about some changes in our audit process and also changes in our supervision arrangements. So in terms of audits, which is where I'm going to start, it's good to go back to what our definition is. And a definition of a clinical audit is a quality improvement process that seeks to improve client care and outcomes through a systematic review and monitoring of care against selected tools, documents, clinical files and our notes. And to satisfy our clinical governance responsibilities, we will be implementing a clinical audit process across all of our mental health programs. So there's a variety of providers here tonight. So some are ATAPS providers, some are MNIP providers. We want to ensure consistency across our mental health program, so we'll be using the same audit tool. So when we actually, in your pack is a copy of the audit tool. So just again to emphasise about why we need to do this, it's a part of quality improvement. If we don't look at our service, we don't know what aspects of our service might need to improve. So just like you might go through quality insurance processes within your own clinics, we need to do that as well. And it really serves as a proactive approach to managing a health service and of promoting a learning culture and a supportive clinical environment. So Sonia briefly touched on the 7 pillars of clinical governance, and we are using those 7 pillars across our mental health services. So again, even though they were designed for ATAPS, they do have application across MNIP, and for us we'll be applying them across our mental health programs. So I encourage you to have a look at the 7 pillars of clinical governance. I'm sure some of you have seen the document, but if you haven't, there's a PDF version on your USB stick tonight. So you can take that away and actually have a lot more information about it. But in terms of some of the justifications, some of the rationales for why we need to implement audits, I will refer you to a couple of pillars, particularly around about Pillar 1, which is all about consumer and community participation, and that pillar really talks about a quality improvement framework. So an audit is a part of a quality improvement framework. And Pillar 2, which is about service access and delivery. We need to ensure that our service is culturally appropriate. We need to ensure that our service delivery aspects are documented. We need to ensure that the interventions we are providing are clinically evidenced, and they have an evidence base, and that they're in relation to the operational guidelines. That looks at service, evaluation, quality improvement and innovation. So we want to ensure that we have a high quality and effective service system. And the way that we can improve that is by taking a temperature of it. How's this currently functioning? What do we need to do better? So again, that's kind of what you do when you're working with clients, which I'm sure that you all do. We want to make sure that the strategies that we're using are evidence-based, and we want to ensure that there is some systematic reviews at the operational and at the strategic level. So again, pretty standard. And we want to ensure that the clinical records adhere to professional practice standards. So again, I don't think that comes as a surprise to anyone. So there's a number of frameworks that providers must comply with. There's the program guidelines and the funding arrangements. There's the National Mental Health Standards. There's your own professional body's practice standards. There's our ATAPS Clinical Governance Framework, and there's legislation around health records, Privacy Information Act, Victoria, and the Commonwealth. So in terms of what are we going to do in terms of audit? So you can see the audit template, which is in your pack. So our clinical audit policy says that we audit in September. So audits will be self-audit. So we want this process to be as, I guess, not so onerous on practitioners. So we believe that our providers are professional people who provide a professional level of service. So when we ask you to audit, we are treating you as professionals, and we're asking you to review your own files. Okay, we can, as the body that has clinical governance responsibilities, we could potentially say to everyone, we're going to come in on Wednesday and we're going to audit your files, and that is within our that's within our responsibilities to perform that. And there's some Medicare locals that actually do that. They will either say we're going to come in on this date. They might advise you of the client records that they're going to access, or they may not. Again, that's their decision to take. So we're going to do some self-audit. So we're going to ask either the practitioner, or if it's an organisation, we're going to ask the organisation to audit the files. So how many files are we expecting people to audit? Okay, so this is where there's a little bit of difference between ATAPS and a MNIP, because MNIP have clients that may be under their service for 12 months plus. So their files are a little bit different to ATAPS. But we are expecting that a provider will audit 5 of their ATAPS files. If it's an organisation with more than one, between 2 and 4 ATAPS providers, we're expecting 10 files to be audited, and for organisations with 5 plus, it's expected that 15 files are audited, and that audit contains a file of every practitioner. If you're a sole practitioner, then we're expecting 5. So for you to review 5 of your files and actually complete the template and then forward that back to me. So what we'll then do at Medicare Local is have a look at the template, and if there are any issues, we want to work with the provider around addressing those issues. It's not a punitive process. It's about saying, what do we need to look at here and how can we improve the service? So what we might do is run further training. We might ask you to raise that within supervision. We might want to have further discussions with you. Really depends on the nature of what has been revealed. For MNIP, we are expecting 2 files are audited, and so when you're reviewing files, you might have to go back to the beginning of the client episode of care to ensure that things like a home visit, if you're performing home visits, that an assessment has taken place. But we're looking for a month of service. So when you're reviewing your case notes, we're looking for a month of active service. So we're not asking you to look through every case note in that file, but we're asking you to nominate a period of service. And so our thinking at the moment is that we're asking you to nominate the files. So you as a provider can nominate your own files. So at this stage, we're not going to go through client lists and say we want these files to be accessed. But we are expecting the files to be clients that have engaged in service. If it's a client that has attended one session and then declined the service, that's not going to reveal much information to us. So it's a client that's actively participated within the service. So any questions on that?
Within what time frame?
Okay, so we're asking this to be occur in September, and so by the end of September, you can provide that back to us.
Files.
Yeah, so
from 5 years ago?
no, so really within the last 6 to 12 months, really. The template is based on the Australian Medicare Local Alliance resource kit. So when Medicare Locals came into existence, the Alliance developed a whole resource kit for ATAPS providers. So what we've done is the majority of that template is actually adapted from them. We've tried to adapt it to our MNIP service, and also so that if organisations are using it as well. There will be an expectation, if you're in an organisation, that your files are a part of that audit. So if it is that you are providing services to 2 different organisations, then it is an expectation within that organisation's audit, your file is there. If you're also having an individual contract with us, then unfortunately, as a sole practitioner, you will then have to do that as well. But that may be something, if that's occurring a lot across the board, that may be something for us to actually have some more thinking about and to get back to you about that. I would assume that is happening to a lesser frequency, but we'll certainly find out. If you're in that situation, certainly talk to us so that we can put some thinking about it. We don't want it to be such an onerous process for providers. The other major change is around supervision, and as you've heard tonight around clinical governance, we have some responsibilities around supervision. There's an inequity at the moment between the two programs in that MNIP we provide an external supervisor and in ATAPS we actually don't. So we're relying on you in your contracts to say yes, you are maintaining your APRA registration, and by default that means that you're doing your CPD points. Okay? So what we want to do is to be able to assist you in terms of addressing some of your CPD requirements. That doesn't mean that the supervision that we're going to provide is enough to meet your CPD requirements. It's not. But in terms of ATAPS, we'll be holding 4 supervision sessions during the new contract with the expectation that providers attend to. With MNIP, supervision will remain the same for 2 out of 3 supervision sessions, but the 3rd supervision session we're implementing a peer review process. So you'll sit down and you'll discuss the client, and you will obtain, you will seek the seek feedback from your peers, and that won't be facilitated by the external psychiatrist. That will be facilitated by yourselves. Okay.
So I'd just like to ask you to refer to the open disclosure document that's in your folders, which really just outlines the process that may need to be undertaken if there is an adverse event that happens to a client whilst they're in the care of yourself, receiving a health service from you. Have you all been able to find it? Because I think there was one missing in the kit that I looked at. It is on your memory stick if there isn't a document in your folder. It's very unlikely that this kind of situation would arise, but it's really just to make you aware that that there is a procedure around sitting down with a client or their family if something goes wrong whilst that person is under your care.